Hello, and welcome to today's webinar on our 2021 calendar, which is part 2 of our 3-part Sexually Speaking Brain Injury Development and Behavior series offered by the National Association of State Head Injury Administrators. I'm Maria Crowley, your moderator for today. Haley Cushion, NASHIA's Coordinator for Member Services and Communications, is our webinar organizer. Thank you so much for joining us. A little bit about NASHIA. We're a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. As always, we're using the GoToWebinar platform today. They provide online support should you experience any issues. Handouts of today's presentation, as well as references for today's presentation, are available for download. Check your attendee control panel for the handouts pane. Please submit your questions in the questions pane, and we will forward those to our speaker at the end of the presentation. If we run out of time, the presenter can possibly respond to your questions via email later. Continuing education credits for social work and certified rehabilitation counseling, as well as general certificates of attendance, will be available for today's event. At the end of the live webinar, you will receive an email with an evaluation. The CEs are bundled for this series. So in order to receive credit, you will need to listen and complete the evaluations for all 3 sessions in the series. The webinar will also be archived for later access on our website under Trainings on Demand. For viewers of the recorded version, please go to Trainings on Demand to find information on how to obtain a certificate. So I would now like to introduce you to today's session and to our presenter. As we talked about for part 1, we are focused on brain injury development and behavior. Today we're going to talk about problematic sexual behavior. And problematic sexual behavior for individuals with brain injury at home or in community can be a real barrier to independence, work, and school. Today's webinar is going to provide you with a basic understanding of the neurological correlates of problematic sexual behavior, and guidelines for recognition, assessment, and management are also going to be discussed. It is my pleasure to introduce you to Dr. Francesca LaVecchia. She's a clinician with over 48 years of experience in this field of clinical neuropsychology and multiple clinical supervisory positions within the continuum of programs. Serving adults and children with both acquired and congenital neurological conditions, including acute trauma care, interdisciplinary rehabilitation, neurobehavioral and psychiatric treatment, and community-based post-acute care. Dr. LaVecchia served as chief neuropsychologist for the Massachusetts Rehabilitation Commission and was instrumental in the development of clinically informed community-based services for individuals with brain injury. Currently, she's a clinical consultant for the Brain Injury Association of Massachusetts and remains adjunct assistant professor of psychiatry at the Boston University School of Medicine. She's also a dear friend and colleague. So, Fran, welcome.
Thank you, Maria. Okay, good afternoon, everyone. Maria highlighted a little bit what we're going to do today, but I'm going to just kind of add a little bit more to that on the next slide. So we're going to talk today in the time that we have to describe some neurological correlates of sexual behavior in persons with acquired brain injury. I'm going to talk a little bit about the potential consequences of misdiagnosis and treatment. And we're going to also at the end focus on guidelines for assessment and management of problematic sexual behavior in community-based programs and settings. So that's what we hope to accomplish in the hour. This is a complicated topic when we start to think about behavioral changes that affect sexuality in people with acquired brain injury. But today I hope to just kind of hit some of the most important issues around that and to give examples. We have the next slide. Okay, so when I'm talking about acquired brain injury, of course, behavior can be affected by all of the major categories of acquired brain injury, which include these etiologies: metabolic, neurotoxic, neoplastic, infectious, and the 2 leading, of course, neurovascular, the second leading cause of acquired brain injury, And because I'm presenting for NASHIA today, I'll probably be giving many more examples about traumatic brain injury, which is the leading cause of acquired brain injury, and touch a little bit about neurodegenerative disorder. So this is what we mean by that whole category. And of course, given the complexities of acquired brain injury, there are many factors that are going to influence the development of neurobehavioral disorders. And those neurobehavioral disorders can include problematic sexual behavior. So overall, we can think about what is the etiology, which we just kind of looked at the major categories, and it's important to note that within each of those categories, we have different types of acquired brain injuries within a category. Age of onset is important, and I know in the first seminar that in the series here, a talk about the development of sexual behavior was in seminar number 1. And I think this is important when we think about not only general kinds of influences of age on the consequences of acquired brain injury, but I think particularly important, as was covered in the first session, how this, sexual development and psychosocial development also gets disrupted in acquired brain injury. Again, particularly with traumatic brain injury, because we have a younger population, whereas most of the acquired brain injuries are going to increase in their incidence over the age of 50. But traumatic brain injury, of course, represents the category in which we kind of see a bimodal distribution, where we have adults with acquired brain injury, again, maximizing over the age of 60, but we also have children and young adults who have acquired brain injury. So age of onset, again, I think particularly important. The sites and the severity of injury within the brain, of course, very important factor. Whether or not a brain injury is progressive or non-progressive, meaning whether or not we're going to see deterioration over time, which could also affect the presentation of neurobehavioral symptoms. Gender, and we'll highlight some examples about that today. And the identification of the neurobehavioral disorder and treatment. This, I find, in all my years of clinical practice, has been, one of the most significant factors in what outcome may be with neurobehavioral disorders, is because very often people, and we'll talk about some specific examples about that, but folks can get diagnosed with other types of disorders and then subsequently be treated for those disorders when in fact that it was not the cause of their problem, and the neurological underpinnings of that disorder were not identified or recognized, and therefore treatment following that. And of course, we have pre and post injury risk factors that are also going to influence the development or presentation of neurobehavioral disorders. So go to the next slide. Next slide. Thank you. Okay, so when we talk about problematic sexual behavior, we have a number of other factors that might enter into whether or not someone's going to develop these types of disorders, which again, if we think about the overall, numbers of people who have acquired brain injury, it's important to recognize that this is a smaller population of people who present with these problems. And factors that might influence that is whether or not they've had a pre-injury history of problematic sexual behavior, whether or not they've had a history of aggressive or antisocial behavior or other types of behavioral and psychiatric disorders, whether or not they have either had a pre or post-injury criminal history, whether there's been a history of sexual abuse, whether or not they are engaged in active substance use. And again, for some individuals, the presentation of problematic sexual behavior can also be affected by prescribed medications. So one, kind of notable example are individuals who are taking anabolic steroids. And I think it's important to note that these things are often readily available now, not necessarily by, prescription or because they've been approved by the FDA, but because they are available online and sometimes disguised as some kind of vitamin. But it's important to note, especially when taking a clinical history, is whether or not folks are taking these kinds of supplements. And even individuals where, for example, hormone replacement has been prescribed, has been clinically prescribed, for example, in people who may have had brain tumors that are affecting the pituitary and the hypothalamus, who then require replacement therapy. And let's say one of those replacement hormones is testosterone. Again, we can see that there can be neurobehavioral consequences of testosterone replacement therapy. Okay, next slide. The other thing, I think, when we're kind of thinking about this population, is it's important to recognize that sexuality overall is not adequately explored in clinical encounters with patients with acquired brain injuries. I know even, teaching students and postdocs and so forth, it's an area that a lot of times people just kind of skip. I think there's a presumption that, the person's had a brain injury and I don't necessarily have to engage in a conversation about their sexual behavior. So I think this is, again, an important reason that at times we are really not addressing what the sexuality concerns are of people with brain injuries, because it's really not part of the intake or people's, exploration of what are the consequences of a brain injury and what kinds of difficulties or challenges people might be experiencing with that. Even if you do a review of the literature, primarily what you see are case studies or incidental observations, or one is talking about sexuality in the context of a specific disease or disorder. And group studies that are done, people have been done primarily on people with temporal lobe epilepsy, or in psychiatric patients who have had psychosurgery, for example, who underwent an amygdalotomy, or for aggression or hyperactivity. So I think, I say this because I think we have a long way to go, not only in terms of making this part of, clinical work that we do with people with brain injuries, but also in terms of even studying it and understanding what the consequences are to sexuality in the context of acquired brain injury. Next slide. So here we have an image of the lateral and medial surfaces of the cerebral hemispheres. And of course, as we're going to talk about a little bit now, to highlight some neuroanatomical correlates of changes in behavior and sexual behavior, it's important to recognize that sexuality is not going to be in one spot in the brain, and that it often involves multiple areas of the brain. And so we may have disturbances because of damage to these surfaces that you see here. And if we look at the next slide, we also can have in the core of the brain, we have the limbic system, or the so-called emotional brain, and we have many structures here that have to do with basic drives, and one of those has to do with sexuality. And so if we look at the next slide, just to highlight some of these areas, we can see that some neuroanatomical correlates that have certainly been studied and identified are areas of the septal region of the brain is involved with the pleasure response and sexual arousal. The hypothalamus is involved with sex drive, and lesions of the ventral medial region can result in diminished sex drive. Areas known as the ansa lenticularis and globus pallidus also involved with sex drive and hypersexuality. The frontal lobes, which we're going to spend much more time discussing today, in the control of sexual behavior. The paracentral lobule, which lies between the frontal and parietal lobes on the medial surface, and the parietal lobe, are involved with genital sensation. And the temporal lobes and amygdala, as we just highlighted in the research studies that are available, are also associated with changes in sexual behavior. Next slide. So we're going to talk a little bit about kind of categories, and I think we'll touch on, as our first section here, hypersexuality, because I think when we think about problematic sexual behavior, this is probably the manifestation of problematic sexual behavior that I have to say in clinical practice is what brings people to attention. People are concerned about hypersexuality. If we had to look overall with people's changes in sexual behavior after brain injury, hyposexuality is actually much more frequently described by people with brain injury than hypersexuality. we can see change in sexual preference after a brain injury. And sometimes that is going to feel to that person, it's going to feel ego dystonic, that they may find themselves engaged in sexual behavior that to them feels foreign and disconnected from themselves. And so that is a possibility also after acquired brain injury. And then we have overall problematic sexual behavior, which, as I said, may include hypersexuality, but this is behavior that typically comes to not only to clinical attention, but it also comes to the attention of law enforcement. And so we have individuals who may incur criminal charges, arrest, conviction, and sex offender status because of the nature of their problematic sexual behavior. Okay, next slide. So we'll start off talking a little bit today about hypersexuality, and what you're looking at here on the screen where you see these nuclei are known as the basal ganglia, and they lie within the telencephalon or the cerebral hemispheres, and they are neurochemically connected to structures, for example, in the brainstem, which you're looking there at that red pathway that you see there is the dopamine pathway. And so, this is an area of the brain that, sometimes as psychosurgery is done. And so let's look at, neurosurgery. I didn't mean to say psychosurgery. Let's look at the next slide. So one of those basal ganglia, which you see highlighted in red there, is the globus pallidus. So here's an example, if we look at the next slide, where neurosurgical intervention was done. The globus pallidus is removed, for example, in Parkinson's disease, and this can result in hypersexuality. If we think about frontal lobotomies, some people become hyposexual after a frontal lobotomy, but others become hypersexual. Unilateral temporal lobectomy, people who've had shunts for hydrocephalus. These are the kinds of case studies and anecdotal evidence that I mentioned earlier that have demonstrated that people can have hypersexual behavior due to these neurosurgical interventions. Neurodegenerative disease can be associated with hypersexuality. And an example of that would be Huntington's disease. And even though Huntington's disease results in extrapyramidal movement disorder in the early stages of Huntington's disease, and when people may be seen initially psychiatrically because they're engaged in disinhibited sexual behavior and may have other neurobehavioral symptoms associated with this disorder, which is a neurodegenerative disease, but it is also a congenital disorder inherited as an autosomal dominant. Prefrontal cortex lesions, and we are going to spend more time on that today, and again, talking about traumatic brain injury. And sometimes you see what appears to be disinhibition and hypersexuality, which occurs, I believe, as a misinterpretation of intent. And, I certainly have been consulted on this kind of presentation in clinical settings, in rehabilitation settings, and also in programs where people are getting care, nursing home programs, other programs where staff's responsibility is to, in fact, touch those individuals, either, for basic care, like bathing them, or they are being seen in physical therapy or occupational therapy. And in the early stages of recovery, sometimes you see this kind of sexual response that happens because of the misinterpretation of intent. And sometimes it is opportunistic, and people who are in the later stages of recovery who are being touched by someone because in the context of care, there is a misinterpretation or there is an opportunistic kind of presentation of what appears to be sexual or disinhibition or hypersexuality in those contexts. So of course, with all of these types of disorders, different approaches are going to be needed depending on what the underlying, etiology and presentation is of these particular types of presentations of hypersexuality. All right, next slide. Okay, you have this comes from a paper by Dr. Tom McAllister, who wrote, you probably know, wrote the textbook of traumatic brain injury. And this is a paper that's online. You can download the whole paper. It's a very good paper, excellent paper on looking at, the issues of, the different parts of the frontal lobes and other parts of the brain that are going to contribute to neurobehavioral sequelae related to traumatic brain injury. And today I'm going to primarily focus on the prefrontal cortex and if you can see there on your diagram, the dorsolateral prefrontal cortex and the orbital frontal cortex. And just to kind of compare and contrast these two behavioral presentations, which of course are not uncommon among people who have traumatic brain injuries due to the focal impact of the brain in the frontal area, as well as other areas of the brain, as well as disconnection that occurs within the brain. So next slide. So we'll start with the dorsolateral prefrontal cortex. And again, we have with this individual, what you see are, if you examine them on neuropsychological evaluation, they're going to have neurocognitive impairments, as well as for some individuals, a deterioration in their general intellectual ability. They have diminished fluency, and if the head injury is maximized in the left hemisphere or bilateral, you might see diminished verbal fluency, nonverbal fluency if the injury is lateralized to the right hemisphere. We have disruption in the regulatory role of language, very important, because if you question those individuals, they might be able to articulate, for example, a rule, and sometimes a rule of behavior, and yet the regulatory role of language is disrupted, and so that even though that rule can be articulated, and how that gets often related to me as a clinician is staff will tell me, well, they know what they're doing, quote unquote, and they understand that this is a wrong behavior. And it's important to understand that, that there's a kind of disconnect that can happen with people with traumatic brain injury where they may be able to tell you what they should do, but then there's a disruption in the regulation of their behavior. With dorsolateral lesions, you also see abulia, which from the Greek meaning lack of will. And so this is a diminished capacity for making decisions, for initiating and sustaining purposeful or goal-directed behavior. And that also can involve sexuality. And so that you can sometimes hear this from, people who are involved in an intimate relationship, that the person with the brain injury seems disinterested in sexual behavior. And this may be a manifestation of the abulia that accompanies these frontal lobe lesions. Next slide. Other things that are described in these individuals, again, apathy. You have what we refer to as the disorder of diminished motivation. And so again, that may be reflected in a lack of intimacy or even caring about intimacy or sexual relationships. And so again, that's how it might present. It also presents in other ways in terms of their overall ability to function. They may exhibit stimulus-bound behavior or affect, that they appear to be socially dependent, that they even engaging in simple social interactions, they may find that they need a stimulus, maybe from another person, to engage in social behavior. And sometimes, people refer to this as people believe that they're depressed. If you often do mental status examinations on individuals who present this way, on mental status examination, they often deny that they are depressed or other symptoms of clinical depression. And so this term pseudo-depression has been used to describe the presentation. It may look like depression, but again, on examination, that person may not endorse the symptoms of depression or feel that they are depressed. At times, even with this dorsolateral syndrome, you can see episodic disinhibition. Okay. All right, next slide. to contrast it, we're now looking at the ventral surface of the brain, or the base of the brain. And to the left of the image there are the frontal lobes, the base of the brain. And let's look at the next slide. And this is a traumatic brain injury. And this is showing you the bilateral damage to the brain. But again, in this case, it is, if we were to flip this brain over, this would be, you'd see that this is maximized in the right frontotemporal area, where you see those two areas. And so this is what we mean by that orbital surface of the frontal lobe. And now let's talk about how these folks present. Let's look at the next slide. So again, you examine these individuals, and you're going to find that they have relatively preserved neurocognitive skills. And depending upon the comprehensiveness of the neuropsychological evaluation, people may even be inclined to say, well, and I've certainly have heard this over the years, well, they don't have any brain injury, and because they have not really done the level of testing that is going to bring out the kinds of symptoms, or taken the history of what is going on with this person outside of the clinical encounter. And that involves really doing a careful, examination of their insight, their ability for decision making, their planning, their judgment, and also, with their consent, to think about, getting some of that information from a reliable informant. I can tell you that examining folks with this kind of syndrome, even for forensic purposes, where a forensic psychologist examines them in a courtroom, for courtroom purposes, will decide that they are fully competent, and based on tests like perhaps an IQ test that's saying that that person is able to make their own decisions, therefore they are legally culpable. And but it's important to recognize that all those cognitive testing can be normal and still have pretty dramatic changes in their behavior, which is really going to be the reflection of what has gone on in that orbital frontal area. So again, impulsivity, diminished capacity for recognizing or anticipating the consequences of one's behavior, either to self or to others. Folks with this kind of syndrome are irritable. They are emotionally labile, often with a very minimal provocation. Something very small can trigger a very big reaction from these folks. Next slide. They can engage in inappropriate jocularity or puerile behavior, it feels immature, and part of that can be sexually immature behavior. They can exhibit stereotypical but correct manners. They can, voice thank you, please, etc. But again, that's often not connected to an understanding of what is socially acceptable. They can be behaviorally inflexible, which can be evidenced in perseveration. And their mood can vary. They can go from, being euphoric to having hypomanic, manic behavior. And we see that kind of mania more with injuries that are lateralized to the right hemisphere versus the left. Next slide. Other symptoms, again, like we've talked about pseudo-depression with the dorsolateral syndrome. With this syndrome, we have what people often refer to as an acquired sociopathy, or sometimes known as pseudo-sociopathy or pseudo-psychopathy. And this is how this becomes evidence. There's a lack of empathy or concern for others, or narcissism. They have impaired social judgment. They have social and physically intrusive behavior. And they can be quite disinhibited, emotionally dysregulated. And this can be manifest in verbal behavior, physical behavior, and sexual behavior, which can be very aggressive and result in, for example, sexually assaulting people or other forms of problematic sexual behavior. This may be associated with a lack of awareness or minimizing the significance of their deficits. Again, lack of awareness of problems in the acute stages we refer to as anosognosia, but often people can kind of resolve to anosodiaphoria, whereas they may recognize that they have a problem but minimize its significance. And again, patients with injuries that are lateralized to the right hemisphere over the left are more likely to exhibit these behaviors. Okay, which also, again, if we're thinking about problematic sexual behavior, poses risks for other people, because there is a dismissing of what the impact of those behaviors might be on other people, or whether or not that behavior is even problematic. Okay, next slide. Okay, so moving on to another type of disorder. I mentioned earlier, not only are all the surface areas that we observed in the brain going, problems can occur as a result of injury to multiple areas in the brain, but as I mentioned earlier, it can also happen because of connectivity in the brain. So what we're looking at here is an image of the right hemisphere and the medial surface of the right hemisphere. And that white area that you see in the middle there is the corpus callosum, which is the main connecting structure between the right and left side of the brain. So let's look at another picture of that. Next slide. So here is a freeze-dried dissection of the corpus callosum. So again, just to get a real appreciation of the connectivity between left and right sides of the brain. And of course, these fibers that go from left to right hemisphere are one of the areas that's also affected due to the kinds of rotational and other forces on the brain that can happen in traumatic brain injury. And also these fibers can be affected in other disorders of acquired brain injury as well. Okay, so next slide. And just to get another appreciation of connectivity in the brain, this is a diffusion tensor image looking at not only the fibers of the corpus callosum, but all of the other fiber systems that you are seeing that's connecting, interconnecting the two hemispheres, as well as ascending and descending pathways that are going from the brain all the way down to the spinal cord. So again, just to get an appreciation of what we mean by the brain's connectivity, which are these myelinated fibers that are seen throughout the brain and between the different sections of the central nervous system. So next slide. We'll talk a little bit about disconnection syndromes. And so one that I think is particularly important in terms of what appears to be problematic sexual behavior is Kluver-Bucy syndrome. And Kluver and Bucy were two investigators who made stereotaxic lesions in rhesus monkeys to explore the temporal lobes. And then, of course, that was done, experimentally. But we also see this, what we saw in those monkeys, we also see in people who may also have Kluver-Bucy syndrome. So let's look at the next slide. So again, what do we see with this disorder? Both in monkeys and humans, you see a hyperorality, mouthing everything in their environment. Bulimia can also happen in humans with Kluver-Bucy syndrome. There's an impulsive reactivity to stimuli or a hypermetamorphosis. And so again, a lot of touching. And again, sometimes that touching is of a sexual nature. The monkeys after the surgery showed diminished aggressiveness, but they could be provoked to aggressive behavior. And in humans, you can kind of see flat affect. And at the same time, you can see that they can also be provoked to aggressive behavior, particularly in long-term studies of people with Kluver-Bucy syndrome. And it presents in monkeys and in humans as what appears to be indiscriminate sexual behavior, that the monkeys after these surgeries engaged in autosexual behavior, heterosexual, homosexual. And in humans, we also can see these presentations, as well as alteration in sexual orientation and verbal sexual disinhibition. A couple of the contributing factors to this, Kluver and Bucy called it psychic blindness. He felt that the monkeys were not relating to visual cues. And so again, we refer to this today as visual agnosia. And it can be accompanied by prosopagnosia, which is a type of visual agnosia that has to do with faces. And individuals also have amnestic disorder that's associated with this syndrome. So if you think about sexual behavior and how reading, if somebody is interested, if someone is responding appropriately to your sexual advances. And again, in humans who have this disorder, these particular, associated findings with Kluver-Bucy syndrome can be one of the reasons that individuals end up what you would call problematic sexual behavior, what it really has to do with complex injury to the brain. And let's look at that for a minute. Let's look at the next slide. So visual agnosia is, again, if you see an object, but you no longer recognize it. It's an object that's been stripped of its meaning. If you examine them, perception, acuity, visual fields, and scanning are usually adequate. These individuals may also have dyslexia, loss of the ability to read, loss of color vision, and prosopagnosia, which is impaired facial recognition. So next slide. So again, prosopagnosia for the individual, the nuance of the face, which of course is a complex visual stimulus, is impaired for these individuals. And this is just an artist's rendition of someone with prosopagnosia. Okay, next slide. So who is likely to have Kluver-Bucy syndrome? Again, almost all of the cases exhibit medial bitemporal lesions. And of the acquired brain injuries, who is likely to exhibit this behavior or have the potential to exhibit this behavior are people who have survived herpes simplex encephalitis, people with traumatic brain injury, people who have had bilateral temporal lobectomies for treatment of epilepsy. And it can also be seen in neurodegenerative disease, particularly frontotemporal dementia or Pick's disease. So there, as you can see, there's a number of syndromes that this might be the presentation. And this syndrome has been described all the way down to preschoolers. And so again, not a disorder that I would say is well known in people that may be working in a variety of settings. I remember one of my more recent cases was an 11-year-old child who had gone through a pretty good recovery after a very serious traumatic brain injury, and then started exhibiting these behaviors at school. And again, the teachers had absolutely no understanding of what was going on, and they were getting a lot of calls because this child was engaging in all of those behaviors that I highlighted, which are part of this syndrome. And the principal was getting all kinds of calls from other parents who were deeply concerned and deeply upset about this child's behavior. And again, this onset of this happened about a couple of years after his brain injury, and back to his pediatric neurologist, and it ended up not only was he exhibiting the symptoms of Kluver-Bucy syndrome, but he was also began onset of temporal lobe epilepsy at that point. So again, this is not, we never expect a school team to know about this syndrome, but I think it's important to recognize that it is a disorder out there that could lead to what is interpreted to be problematic sexual behavior. All right, next slide. Another, again, I think less well-known syndrome is genital automatisms. And these are seizures. So these may be evidenced in, I put some references in your handout, but these are can be evidenced in all types of manifestations of sexual behavior. And again, you can see how this would lead to people being labeled as sex offenders or people with problematic sexual behavior. So again, touching oneself, grabbing or scratching the genitals, it's associated with temporal lobe epilepsy, can occur in the ictal phase, as during the seizure or in the post-ictal period. The individual has amnesia for the event, more often observed in males versus females. It can be on one side, that is, you can have a unilateral hand automatism, and it can also be associated with a periictal, that is around the time of the seizure, urinary urge. You can have much more aggressive type of genital automatism, that is hypermotor sexual automatism. If you were observing this person, it would appear that they are engaged in sexual behavior. And again, this can be a manifestation of orbital frontal seizures. Next slide. Parietal lobe seizures can result in heightened arousal. Again, often very confusing to the person. They have genital sensations. They may perceive them as ego-alien. They're irritating. They're frightening. The person doesn't want to talk about it. And this also can occur during a parietal lobe seizure for which they are conscious, and also involved in the paracentral lobule paresthesias, or tingling and other manifestations of sensory arousal. You can have sexual and orgasmic auras that can also occur in the context of seizures. So again, seizures may be another way in which problematic sexual behavior may be manifest. Next slide. Okay, and important to just recognize that we have not only in many areas of medicine, but we have healthcare disparities, particularly around seizures. Minority populations have a higher incidence of epilepsy than whites. Native Americans, for example, have doubled the prevalence. Of the 3.2 million people who have epilepsy in the United States, 40% are women of childbearing age, but few minority women seek care. The incidence of status epilepticus, or prolonged seizures, is significantly higher among African Americans than non-African Americans, particularly in the young and in the elderly. So again, important in terms of recognizing seizures in general, but certainly some of these seizures that I'm talking about with you today, which are less common. Okay, next slide. Other healthcare disparities, I think, in terms of recognition of these neurobehavioral disorders, including the ones causing problematic sexual behavior, are geographic and cultural isolation, people's socioeconomic status, the lack of access to clinical specialists, lack of translation services and cultural competence of the clinicians, and lack of knowledge. Again, if we had to look at people prescribing medications for people with acquired brain injuries across the board, 70% or more of these individuals are not being seen by individuals, clinicians who have a background in neurology or psychiatry even. And so, again, when we think about some of these syndromes I'm going over with you today, lack of knowledge about the syndrome itself, responses to medication within different ethnic and racial groups or ethnopharmacology, or recognition of the neurological disorders and conditions. Next slide. So just to segue into that, when we have, as I mentioned at the beginning of the presentation, when we don't recognize what the syndrome is, then of course, lack of recognition, lack of identification, lack of assessment is going to lead to lack of appropriate treatment. And I think that we have a pretty long history of this in terms of people with disabilities. I put this book in your handout here, the references today, 3 Generations of Imbeciles, and some of you may be familiar with this landmark case of the Buck family. And but those of you who are not, just let me highlight this. Next slide. Okay, so the Buck family, Emma Buck was a widow that was accused of being a prostitute, immoral, and a pauper, and she had 3 children, and she was committed to a state facility in Virginia. And this was really a woman whose husband had left her, and she had a very difficult time, and she was put in an institution as a result of people deciding that she was an immoral person. So here's where we have that kind of, misapplication of thinking that somebody has a sexual disorder. Her daughter was adopted, and in the care of the adopted parents, she was actually raped by the nephew of the adopted mother. And because of that, and she became pregnant, they put her in the same facility as her mother in the Virginia State Colony for Epileptics and the, quote, feeble-minded. And again, prior to this, she had been going to school. She had no evidence of any sexual, intellectual disability. And when they admitted her there, she was sterilized. And of course, this was a very famous case that went to the Supreme Court because it was during the time that states were passing laws that they were wanting to sterilize people with disabilities. And this was really growing out of the eugenics movement in our country, which started in the 1920s, of trying to basically purge the population of people with, quote, disabilities and that were feeble-minded or mentally ill. But of course, many of these people were just poor. And so we will talk a little bit about what happened when that case went to the Supreme Court, but basically it was sanctioned. Her sister was also put in the same institution, and they decided, and as well as her brother actually, but her sister was also sterilized at age 13. And Carrie Buck had a child, Vivian Buck, who they actually placed with the same adoptive parents. And again, she had no intellectual disability, and she actually ended up dying of measles complications at the age of 6. So why was this case such an important landmark case? If we look at the next slide, is because basically the state of Virginia wanted to use this as the test case that people could be sterilized without their consent. And as amazing as this quote may seem, and it was the title of the book, that Justice Oliver Wendell Holmes, the famous jurist, actually said in his opinion, it is better for all the world if instead of waiting to execute degenerative offspring for crime or to let them starve from imbecility, society can prevent those who are manifestly unfit from continuing their kind. And this landmark case really set the stage for sanctioning the sterilization of individuals. Okay, next slide. This is a picture actually of Emma Buck and her daughter sitting at the institution. Next slide. And this is the sign that is out there that today that talks about, and you can kind of read that, about how many other Virginians had been sterilized, again, set off by the sanctioning of this by the Supreme Court. And incidentally, that was never overturned. And as you can read on this sign that sits in Virginia, that this law was not repealed in Virginia till 1974. Okay, next slide. So this, of course, was not just happening in Virginia, it was happening all over the country. And again, as I said, directed at people with disabilities. And, you know, and I'd like to tell you that people still don't, that people no longer think about sterilizing people with disabilities, but they do. I've certainly have had that requested with, in clinical encounters where families have asked to have their family members sterilized. So even though this is about 100 years ago, it's important to recognize, I think, and to remember this history. And this, by the way, this sign doesn't look too much different. This is a sign from the United States, but it doesn't look too much different than the signs that Nazi Germany put up during the reign of Hitler. And the Nazi policies, by the way, were developed to sterilize people in Germany based on what was going on here in the United States. So again, a bit of a shocking history into that, but it is true. So next slide. So just to show you how many states had sterilization laws and how long they stayed in effect. And let's look at the next slide. Okay, so compulsory sterilization laws were adopted in 32 states and they were federally funded. Estimated more than 65,000 sterilizations, and that's probably just you regard that as a minimal estimate. So because we don't really know how many people were sterilized. This is not exactly the epidemiology at that time. I don't think was really keeping up with how often that this was happening. But 61% of them were women. Other sterilizations were performed on poor and disadvantaged individuals or on specific racial and ethnic groups. For example, between 1970 and 1976, 25 to 50% of Native American women were sterilized. And even recently, in 2006 to 2010, 148 female prisoners in California in 2 different prisons were sterilized without their consent. So it's not that distant in terms of how often this has been happening. And I think people with disabilities and certainly people with brain injuries are at greater risk and have historically been at greater risk. Next slide. So here we have Dr. Walter Freeman, who was one of the greatest proponents of doing lobotomy procedures in the United States. I mentioned lobotomies earlier, how this can lead to hypersexuality, but it's important to recognize that lobotomies, which were still being performed until the late 80s, 1980s, were also done in response to what were perceived to be people's sexual behavior. So next slide. This is another book I put into your handout here, The Lobotomist, which is a very well-researched book on Dr. Freeman, but just to highlight, next slide. Dr. Freeman alone performed, allegedly 3,500 to 4,000 lobotomies using what is known as the ice pick procedure, going through the eye orbit to impact the prefrontal cortex. He even did this to children. He did it without anesthesia or informed consent. And of course, we still have people in state institutions who were the victims of lobotomies. He had no formal surgical training. He disregarded sterile procedure. He initially was brought in a neurosurgeon to assist him, and that person, Dr. Watts, actually withdrew from working with him. And these surgeries were performed to change sexual orientation and to treat other sexual behavior. So again, we have the misapplication of these very invasive procedures for sexual behavior. Next slide. Okay, and he was a racist. And so again, he believed African-American psychiatric patients, and it's unclear why they were put in psychiatric facilities to begin with, especially women, were the best candidates for lobotomies because of their, quote, greater family solidarity manifested in these people. He did many lobotomies on individuals in the West Virginia State Hospital, and he even offered to perform lobotomies on people in the Tuskegee VA Hospital. And again, they stopped him from doing this. So he had quite an impact, in terms of his, misguided lobotomy efforts. Next slide. So lobotomy outcomes, probably 60,000 lobotomies were performed between 1936 and 1956. Again, women more than men. These people had acquired brain injuries just by virtue of having the lobotomy, cerebral hemorrhage, seizures, brain abscess, neurocognitive and neurobehavioral deterioration, and death from these procedures. Next slide. So again, lobotomies, one of the most invasive of the, procedures to, quote, treat sexual disorders. But there's been a whole host of these things done. Genital shock treatments, conversion therapy to, quote, cure homosexuality, which has been condemned by the United Nations in 2004 as a form of torture, removing the ovaries and the clitoris of women, and castration, both surgical and chemical. Next slide. Again, the impact of these kinds of procedures started really back in the 1800s with this Dr. Baker Brown in Great Britain, and again, who attributed all of women's problems to their ovaries, and he removed them, including on his own sister. This is again just blatant pseudoscience, and he performed removal of the clitoris in response to his belief that all nervous disorders were the direct result of peripheral excitement of the pudic nerve, which again is the nerve that would be engaged during masturbation. Next slide. This is his book, and again, pseudoscience, the curability of certain forms of insanity, epilepsy, catalepsy, and hysteria in females was his treatise on this. And this may seem like a long time ago, but let's look at the next slide. All right, this goes on to this very day. So the female genital mutilation is something that is of concern at a global level. And let's look at the next slide. And these are the countries where this type of invasive procedure is being performed. And again, the same kinds of things: removal of the clitoris, or excision of the external genitalia of women, sewing up their vagina. And again, why are these procedures being done? If we could look at the next slide. Okay, actually, let's look at our current epidemiology on this. So the World Health Organization estimates that 200 million girls and women alive today and are living with the results of female genital mutilation. It's estimated that 3 million girls, infancy to age 15, will be subjected to this annually. And the rationale, quote, for providing these procedures is to ensure premarital virginity and marital fidelity, and that the notion that girls are unclean, unfeminine, or male. And in the United States, we passed a law against this, making it a felony to perform these surgeries in 1996, actually, on anybody under the age of 18. However, in 2018, a federal judge actually struck it down as being quote, unconstitutional, and it actually just didn't get put back on the books until 2021. And there are only 39 of our states actually have laws to prevent this in children. So this is still, and this sounds like, as I said, it sounds like something that was long ago, but this is still going on today. Okay, next slide. This is a young girl in Nigeria that, again, there is being made to change this on a cultural level to protect girls, and as you see, protect girls and say no to FGM. So let's look at the next slide. So I kind of highlight some of this historical and current information about interventions about sexual behavior. And again, what happens when people get subjected to these things? They have exacerbation of their sexual disorders. They can develop secondary psychiatric disorders, depression, suicide and suicide attempts, and substance use disorder. And that has been very well documented in individuals who have gone through these, quote, treatments. They can, of course, as we saw with lobotomies, result in neurological and other medical consequences, as we saw in female genital mutilation. And of course, today, and I certainly still see this in my clinical work, that people end up institutionalized and incarcerated for what is determined to be inappropriate sexual behavior. Next slide. Okay, just a word about hyposexuality. I talked about it in terms of the dorsolateral syndrome of the frontal lobe. But again, you can see hyposexuality with hypothalamic surgery, again, that has been performed for sexually deviant behavior, or what people believe to be sexually deviant behavior, and surgical procedures for movement disorders. So you can see both hyposexuality and hypersexuality in planned neurosurgical procedures for movement disorders. We can see this with dementia and neurodegenerative diseases. We can see it with temporal lobe epilepsy as a so-called interictal personality trait. With right-sided temporal lobe epilepsy, there's an increased incidence. And we can also see it with prescribed medications. So the medications that people are given, and again, we see a lot of times individuals with acquired brain injury are prescribed often a lot of medications that are designated or prescribed to control their behavior, and as well as medications that are not necessarily for their behavior, like gabapentin, that also can cause hyposexuality. And again, patients often complain of side effects of medications, not only people with brain injuries, but people who are given, for example, antidepressants that affects their sexual behavior. And again, these are things that need to be explored in clinical encounters, because if not, people will just stop taking these medications because of the impact it's having on their sexuality. Okay, next slide. Okay, so in the time we have left, I wanted to just, highlight some best practice guidelines. First of all, as you can see from what we went over today, and it was a lot to put in an hour's presentation, but I think you probably hopefully have gotten the idea that we need to get comprehensive medical, psychiatric, psychosocial, sexual, and forensic history on individuals that are presenting with problematic sexual behavior. I'm a neuropsychologist, and even though I might explore some of these things with I see, it's important to understand that if somebody really does have problematic sexual behavior, that they're problematic sexual behavior clinicians, that this is in fact their expertise. And when possible, it is really important to make sure that that individual has also had experience with evaluating people with acquired brain injuries, other neurological disorders, and for individuals who have intellectual disability, because I think one needs to take into account how that behavior is presenting in the context of those syndromes. Assessment of the person's current mental status, neuropsychological evaluation, because if we're going to come up with strategies to work with that person, it is best that that is based on neuropsychological assessment so that we can have those strategies be cognitively informed to be most beneficial to individuals. Neurobehavioral support plan, which should be informed by the risk assessment, and as I mentioned, their neurocognitive status. Understanding how that person best learns is going to be important in terms of developing any kind of behavior plan that has been developed to specifically address problematic sexual behavior. Next slide. When indicated, as I mentioned, the young child that I talked about earlier who had post-traumatic presentation of Kluver-Bucy syndrome and seizure disorder, again, when necessary and indicated, behavioral neurology consultation, psychopharmacology evaluation, especially if people are having problems with sexual behavior that might be related to medication. Individual or group psychotherapy, again, preferably with a clinician experienced in working with neurological populations. And I just want to say a word about, there are sometimes groups that are run for people who have perhaps sex offender behaviors or problematic sexual behavior. And one has to really consider whether or not that is the appropriate group for somebody with an acquired brain injury. I certainly have seen people placed in those groups who have acquired brain injuries, and then they have, unfortunately, a very stimulus-bound kind of reaction to being in that group, which sometimes can increase their sexually disinhibited behavior. Additional risk assessments when indicated. Sometimes problematic sexual behavior is accompanied by fire setting behavior, which again requires its own evaluation. We need to think about capacity to consent to a sexual relationship. This has particularly come up in situations where I have been asked to consult where people are in residential settings or nursing home settings, and they may have a neurodegenerative disorder, and it's unclear whether or not they are actually consenting to a sexual relationship, or whether or not that person has an intellectual disability or some other type of neurobehavioral disorder that may put themselves at risk or put others at risk. Next slide. Each state has its own way of addressing registration for adjudicated sex offenders. Here in Massachusetts, it's the SORB, the Sex Offender Registry Board, but whatever other legal requirements are there. And I think, again, we've had situations where people were sex offenders, adjudicated sex offenders before their brain injury, and now they maybe perhaps did not remember that they were a sex offender, but they still have to follow the requirements here in Massachusetts for the Sex Offender Registry Board. And if they don't register for that, again, that could bring other consequences to them. So again, understanding what the state requirements are for individuals who have in fact been legally adjudicated to be sex offenders and what level sex offender that they are. This also pertains when we have residential programs and other community-based Residences, where those residences are cited, again, is another thing here in Massachusetts. Again, if you are a level 3 sex offender, that's all online here in Massachusetts. And so putting up a residential program that has adjudicated sex offenders in a neighborhood is something, again, that needs to be carefully considered when you are putting people in the community. If people are in programs and they have sex offending behaviors or problematic sexual behavior, one really needs to think about roommate compatibility and potential risk vulnerability of the other people in that context. And this may also pertain to any other institutionalized or group setting that people may be in. In those settings, staff ratios, selection, training, and ongoing support needs of staff are very important. And for the individuals themselves, cyber risk education, I think, is quite an important thing to think about, not only because, we have many clients who are on these websites, and again, perhaps they are going to sites that are illegal, like child pornography sites. We've had situations like this where, in fact, they were even using the program computer, and these sites are all monitored by the government. And so they have ended up with potential charges as a result of their going to those sites or distributing pictures. They also are at risk for victimization. So we've had people, again, in an effort to have some kind of sexual life, have been victimized by people online. They have sent them their money, they have sent them their Social Security benefits, and in fact, sometimes have resulted in people becoming homeless because they were not able to pay for their daily expenses because they had been expended by people who basically had scammed them online, at times even promising that they were going to have a wife delivered to them, for example, via the internet. So people with brain injuries, I think everybody needs this kind of education, particularly younger people as well. But I think that, people with brain injuries very much need this kind of education so that they understand what the risks are on the internet. Next slide. Okay. And just so you know, child pornography law, the production, distribution, reception, and possession of child pornography is a federal offense. It includes anything: videos, photos, digital, computer generated, even undeveloped film. And the child does not have to be engaged in any kind of sexual act. It can just be sexually explicit. Child pornography is not a First Amendment right. And it's important to recognize that these have very severe penalties for them, 15 to 30 years for a first-time offender. And if these are really violent, sadistic, masochistic, or depict sexual abuse, they may face a lifetime imprisonment. So again, educating people about this. And some of our clients end up on these sites because they maybe sometimes gravitate to a younger age group. And again, because of been their own kind of disrupted psychosocial and sexual development at the time of their injury. Next slide. Okay. So sexuality, again, it's a domain of human behavior and functioning, which is largely not addressed or assessed in persons living with acquired brain injury. Changes in sexual functioning affect an individual's perception of themselves, their quality of life, and also their intimate partner. And so I'm just going to say that I really feel we have quite a way to go with this among people with brain injury, that we need comprehensive education, we need policies and programs and services and psychosocial opportunities in the community that serve people with acquired brain injury. And I'm going to stop there. And I think we have about 5 minutes left. I'm not sure if there are any questions in the chat there, but I just wanted to leave a little time. And I know that was a lot to go through in an hour, but so let's.
Oh, that was, but beautifully handled. So many takeaways. I've made so many notes just for myself. We do have a couple of questions, and if I may just read a couple of these off to you to address in the time we've got. You mentioned early on about seizures triggering sexual behavior. How frequently occurring is that?
I don't think it's common, but on the other hand, again, we're looking at small studies that are done on people with known seizures. And I don't think it's something that comes to mind for people. I think that it's, again, I can think of a child that I had who had serious brain injury, pre-adolescent. And when that behavior emerged, and it was a seizure, he was having frontal lobe seizures, um, his parents could barely come in to talk to me about this. Initially, they hid it because they were really worried. But he also had, he was a person who had sisters, and that was what brought them in. So how often it's really happening? Truthfully, I don't think we really have thorough epidemiology on that, and I don't know. I usually, when I give this talk, most people have never heard of genital automatisms. And even when I talk to my students about it, they have never heard it in a single class. And so it's something that, but I think it's important to recognize that, especially when the person says to you, I didn't do that, or I didn't remember doing that. So
Right.
again, clue that maybe they were not conscious when that happened. And it can happen just before the seizure or right after the seizure. So it's not, doesn't have to just be the seizure. So again, I know I ran through that pretty quickly, but it can be pre-ictal, ictal, or post-ictal. So, and again, there's a good paper in there that I put on the list, which I think is probably one of the more comprehensive studies I've seen of looking at that behavior.
Great, thank you. And again, before we wrap up today, go ahead and download the references. So you will have all of the things that Fran alluded to on your own laptop. Here's a two-parter. And with NASHIA and in several states, folks are addressing brain injury in criminal and juvenile justice. It's always a challenge to determine if brain injury is a mitigating factor in terms of why the person committed the crime. If the brain injury is likely causing some of the sexual dysfunction, is this something that should be considered when a person's facing legal consequences? And the second, well, I'll stop there.
Let me answer that first.
Okay.
I think, of course, if we go back to some of the earliest studies on this done by Dr. Dorothy Otnow-Lewis, and this was done on people who were on death row, where she went back and documented, every single one of them had traumatic brain injury, and many of them had more than one traumatic brain injury. And their brain injury was never brought up as a mitigating factor. And so again, I think this happens commonly. Okay, so here in Massachusetts, I have spent time training, particularly the public defender's office, because a lot of times individuals with brain injury, that is who's defending them. And what has been available to them is, the court psychologist. And that's why I brought that up earlier in the presentation, was because, the court psychologist is not a neuropsychologist, is not a neurologist, is not somebody who is, and again, I don't say that in any way to discredit them. It's just that is not their expertise.
Okay.
And so here, I've really, strongly encouraged the public defenders here when I have trained them, is that you need to think about all these things and to what extent the brain injury is a mitigating factor. You have somebody with an orbital frontal syndrome, yes. I mean, and like I said, if they got evaluated by the court psychologist, their IQ is normal, they're competent to stand trial, they're responsible for their actions without recognizing the injury to the brain. And so I think that this is something that, again, when we think about educating, not only in our brain injury community, but when we think about juvenile justice or just the justice system in general, this is something that I feel is another part of what we need to do to advocate for people with brain injuries, is we need to cross-train this group. I mean, we need to understand what they need to do, and they need to understand about the brain injury. And when they need to go to the judge and say, we need an expert opinion, not just an IQ test. And so I think, yeah. So I do feel that that is very important, and for each individual it's going to be different. But that's how it has to be addressed, is if it's a mitigating factor, to what degree is it a mitigating factor? And that can only come from comprehensive assessment.
Yeah. And then, just the last part of that question is, if that is the case, what strategies do you recommend in terms of sex offender treatment, which probably could be a whole other session.
Oh, yeah, that could be a whole other week, Maria. So, I think that that is, again, and Maria knows this, but here in Massachusetts, we have, I have partnered with people who do that work, and how we're going to deal with problematic sexual behavior. And again, how do we deal with this even across agencies, even, like people who are intellectually disabled, people who have acquired brain injury, people who are mentally ill, that we need to think about this in terms of consistent public policy around this. And for programs that are being funded, for people with all of these disabilities, it needs a comprehensive plan, and that has to include experts in problematic sexual behavior, as well as people who are experts in developmental disabilities and brain injury and mental illness.
Right. Thank you so much. That's so incredibly helpful. And maybe we do have a next part that, hits on those things. I certainly think we could. Appreciate your time and your energy and passion and commitment to this topic, Fran. As always, so informative and so well put together.
Thank you so much.
We appreciate you.
Okay.
Thank you. If you enjoyed today's event, stay tuned for the last part of the series, which we rescheduled for August 11th. Kyla Browning is going to focus on forming and maintaining relationships during her session. Please join our other training events, as well as check out our products, podcasts, and leading practices academies. And we're also hoping you'll save the date for our annual event, the 2021 State of the States Conference. Registration is open. NASHIA is a membership organization. Consider joining. More information can be found on our website. Thank you for viewing today. And as a reminder, our evaluations need to be completed at the end of this webinar. And remember that the CEs are bundled for this series. Contact us if you want to receive notice of any other future events. And have a great day.